Today I'm going to demonstrate female catheterization. Catheterization is an invasive technique. There is an element of risk of introducing infection to our patients, so we have to minimize that risk as much as possible. Having washed our hands with the chlorhexidine, we can take our trolley to the patient and start opening the packs. But do make sure that you're not compromising the patient's privacy and dignity. So make sure that the curtains around the bed are fully closed and that you're not going to be disturbed. If you can work with another practitioner, then that's helpful. It's good to have the reassurance for the patient. But today I'm going to show you how you would catheterize as a single practitioner. So opening our packs. We're going to open the pack using a minimal touch technique. So just opening the pack and then carefully tipping it onto the top of the trolley. Then we're going to create our sterile field. So just touching the very edges of the wrapping paper, we're going to open the pack. Now right on the top of the pack is a clinical waste bag, which is quite useful because I can use this as a makeshift sterile glove to move things around the sterile field, putting the equipment in an appropriate place for me to work with. So making sure I've got a galley pot there. Now the galley pot I'm going to put closest to the patient and to me, so that I'm not stretching across my sterile field while I'm collecting things. There's one pair of sterile gloves already in this pack. Now in these packs the glove sizes tend to be small to medium, so if the gloves that you normally wear are larger than that, then you would need to get 2 pairs of sterile gloves in the appropriate size. There's a thin water resistant sheet and there's a tissue sheet which we're going to use later on to create sterile fields around our patients. Also in the pack we've got some gauze squares, and this little container serves as a receiver. We need to fix our clinical waste bag close to us so that anything that we're using on the patient goes straight into the clinical waste bag and doesn't get put back onto the sterile field. And then we're going to open all of our other packs. First of all, I'm going to open the normal saline. And I'm going to tip it carefully into the galley pot, disposing of the container straight into the clinical waste bag. Then I'm going to open the Instillagel. Now this Instillagel contains about 11 ml of lubricant. For a female catheterization, we're probably going to use 5 to 7 ml of that, and the residual we'll squirt somewhere on the sterile field so that we can lubricate the tip of the catheter as well. And then we're going to open the catheter itself. On the back of the catheter packs we've got these little sticky labels. Now these sticky labels enable us to trace this catheter right the way back to manufacture. This is important if we had a patient that were to develop a catheter-associated bacteremia. Open the catheter very carefully, but leave the inner packaging intact. So just tip it carefully out onto your sterile field. And then we're going to open the second pair of sterile gloves. Putting on our sterile gloves, the first pair that we put on needs to be the pair that fits us the best. These are actually going to be the gloves that come into contact with the catheter. So put them on very carefully in the same way that you would put on gloves in theatre. So make sure that your fingers do not come into contact with the fingers of the gloves. Then we're going to put on the second pair of gloves. These are a little bit easier to put on because you've already got one pair of sterile gloves on. These gloves I tend to think of as my working gloves. With these gloves I can touch the patient without compromising the sterility of the gloves underneath. So now we're going to approach our patient. At this point we can expose the patient, but make sure that you don't expose the entire patient. Try to retain some privacy and dignity for the patient by only exposing the area that you're going to be working in. Now this is an Inco sheet, it's absorbent, and we use those because putting the catheter in can make the bed wet. At least this way the absorbent sheet is going to absorb any moisture that we create and the patient isn't going to be left in an uncomfortable position. And we're going to start by cleaning the patient. So we need this patient to be on their back, semi-prone, knees up, heels towards their bottom, and then the knees flopped apart. And we're going to clean the patient by wiping one gauze swab from front to back and then discarding. And we're going to do that 3 times. So just parting the labia, we're going to go from front to back, one wipe, and discard, and then we're going to repeat the process on the other side. So one wipe down and discard, and then finally one wipe down and discard. And then we're going to insert the Instilla gel. So take off the little cap cover. You're going to need to part the labia and very gently insert the nozzle of the syringe. Now we might need to warn the lady that it's going to be cold, a little bit uncomfortable, might sting a little bit, but we'll very gently insert around 5 to 7 mils of the lubricant gel. And the residual we can squirt onto our sterile field and discard the syringe. Now at this point we can take off our working gloves. Take them off carefully, making sure that you don't contaminate the gloves underneath, and discard. Now we're ready to create the sterile field. So we can start by opening up the tissue square, making a small tear down the centre and placing it over the lady's vulva. We need to make sure that the lady doesn't contaminate the sterile field, so we ask her to cross her arms across her chest and keep her hands away, and we just position so. This sterile sheet we can open and just lay across the bed so that it would be extending our sterile field, and that way anything that comes into contact with this is not going to become contaminated. Now this inner bag has got little perforations which run down the length. We're not going to open the bag completely, but we're going to tear down the perforations just enough to expose the tip of the catheter. And that tip of the catheter we're going to dip into the residual lubricant gel that we've squirted on our sterile field. Now, parting the labia, you need to expose the meatus of the urethra and very gently just pop in the catheter. And we're going to carry on inserting until we reach the bifurcations . What I try to do is to keep my thumb and 4 fingers away from the patient so that I can actually grip the catheter without compromising its sterility. Now we want to make sure that the catheter doesn't fall out, and we do that by inflating the retention balloon. So the end of the catheter that has the valve, we very carefully insert the full 10 mils of the sterile water that is in this catheter, in this syringe, into the catheter. And we're watching the patient's face all the time that we do this, because we want to make sure that we're inflating it in the bladder and not in the urethra. And then we can pull back until we feel resistance, and then we're ready to connect the drainage bag. Now the drainage bag is also a sterile piece of kit. Some drainage bags are bed bags and can hold a litre of fluid. Others are leg bags and will hold half a litre of fluid. This is a leg bag. We connect the bag by removing the bayonet cap and carefully inserting it into the open end of the catheter. It's important that this doesn't pull on the patient's pelvic floor, as this is going to weaken it and can create incontinence after the catheter has been removed. So we make sure that it's secured appropriately with the little Velcro strips thread through the holes here and securing it to the patient's leg if they're mobile. If the person is bedbound, then we're going to want to use a bed bag and make sure that that is connected to the side of the patient's bed. It's important that the taps of any drainage bag do not come into contact with the floor, as that gives a direct route for any microbes to travel up and into the bladder, creating an infection for our patients. Once we have finished the catheterization, we wipe any residual gel from the catheter itself. We make sure that we leave the lady as comfortable as we can, taking away any wet incontinence sheet, leaving her bed dry. And then we would complete the appropriate paperwork. I'm going to demonstrate male catheterization, and it's important to recognise that nurses are taught how to catheterize female patients as part of their general training, but they're not necessarily taught how to catheterize a male patient until a postgraduate course. So the first catheter that gets passed into a male patient has to be passed by a doctor. Doctors are taught how to examine a prostate gland, for example, but nurses are not. So making sure that we've got a safe insertion by a competent, capable practitioner is paramount. The infection control aspects, reducing the risk to our patients of catheter-associated infections, are just the same with a male catheter as they are with a female catheter, but the technique for putting the catheter in is different. We're going to wear protective personal equipment again, as we're dealing with a body fluid, and we're going to wash our hands using the chlorhexidine hand wash to disinfect our hands. We're going to use Instilla gel the same way as we did with the female catheterization, but we're going to use more of it to accommodate the extended length of the urethra. We need to let the gentleman know that this is going to be cold. It may sting a little bit, but we'll be as gentle as we can be. So just carefully hold the penis erect, put gentle pressure on the head of the penis until the meatus opens, and then gently insert the nozzle of the syringe. Slowly and carefully insert around 7 to 10 mils of the lubricant gel. Now it will ooze around, so don't squirt it in too quickly. We want to give gravity a chance to take some of it down the shaft. And any residual we can squirt onto our sterile field. Now we're ready to take our top pair of gloves off. Take them off carefully so that you don't contaminate the gloves that you're wearing underneath, because you are going to be touching the catheter with the gloves that you're wearing underneath, so we want to maintain their sterility as much as possible. We create a sterile field. I tend to put a gauze square just across the gentleman's penis. I create the sterile field by opening the tissue and then making a small tear down the middle, just just as we did before. But now I can use my sterile gloves to just lift the penis through and make sure that it is on the sterile field. And again, we can use the plastic sheet just to put across the bed, so should the catheter touch the bedding, it's not going to become contaminated, it's going to touch another sterile piece of equipment. Just as with the female catheterisation, we're not going to take the catheter out completely from this little coloured bag. Just gently tear down a few centimetres of the perforations until we've exposed the top. So, holding the penis erect, just very gently drop the tip of the catheter into the meatus. You may need to put a little bit of pressure on the head of the penis to open the meatus. And you notice that I hold the penis with my 3 fingers and the heel of my thumb, keeping my forefinger and my thumb free to grasp the catheter. It can be quite tricky putting the catheters into male patients, so if you certainly don't want them to fall out. Now there comes a point where you reach the prostate catheter over the prostate gland. Lower the penis so that it's straight and just gently exert a little bit of pressure. You shouldn't need to exert too much pressure, and if the patient is in any pain or discomfort, then you stop and you remove the catheter. We're going to insert the catheter as far as the bifurcations. And then we're going to inflate the retaining balloon. Now we do this by inserting the full 10 ml of sterile water into the retaining balloon. We're doing it slowly and steadily and watching the patient's face for any signs of discomfort. If there's any pain, any discomfort, then we stop and we remove the catheter. We don't want to risk inflating the balloon in the urethra and rupturing it. And then we want to attach the drainage bag. Again, if you have a mobile patient, we can use a leg bag so that that person can mobilise freely. But if we've got a bed-bound patient, we may want to use a larger bed bag. Once we've connected the bag, we can then pull back the catheter until we feel a little resistance. Wipe off any residual gel. Leave the catheter on the patient's bed and remove the catheterisation equipment. But before we leave the patient's bedside, we make sure that the leg bag is secured firmly to the patient's leg, or a bed bag is secured to the side of the patient's bed.